progressive orthodontic seminars. I think it's the best comprehensive education out there. So do you guys have any questions that didn't get answered or anything that you are particularly interested in that you want to ask a question about?
I have a couple. For patients who come in and they need like an RP, they need more maxillary expansion, but they only want aligners. Do you have like a common patient that you tell them in the treatment plan? That you tell them we're going to start with braces, we're going to expand and want aligners? Well, expand with aligners?
Interestingly, aligners are better at expanding than braces are.
Do they have a limit?
Yeah. So about 2 millimeters per side. Okay, so aligners, if we do braces, we're trying to expand by using an arch wire that's wider than their arch, but it's still just a little wire. There's not a lot of the wire's ability to like pull everything out. So we're limited. We do have bigger arch wires, and on younger patients, they actually do a pretty good job, but sometimes on older patients whose bones don't want to remodel that much, we're kind of limited. But with an aligner, you have intimate contact with the lingual surface of the teeth, so they actually do a better job of expanding, but yes, we're limited by the bone. So wherever their buccal plate is, some people have real wide dental alveolar arches, like the process, you know, you look at the scan and you're like, this is a really big chunk of bone with a tooth in it. There's room to move this tooth out to the buccal. Other people, the tooth is already up against the outer edges of where it can go, and if we keep pushing it, it's just going to tip. The crown will just start to tip. So we generally say 2 millimeters per side, so a total of 4 millimeters of lateral expansion. Younger patients, you can maybe get away with 3 per side because they're growing, they're a lot more able to remodel their dental alveolar process, their cortical plate, and actually reshape their dental alveolar process. But again, there's a difference between patients who need dental expansion and patients who need skeletal expansion. So when we have a younger patient who needs more expansion, that's when we put in that like bonded RPE or a quad helix. There's all kinds of different expanders out there. You know, there's even removable retainers that people use, little cranks and stuff like that. That generally we're trying to get skeletal expansion, and they have to be young because that suture has to have not fused yet. So we can pop that open and actually expand their maxilla. If they're an older patient, over 20, 21, something like that, and we want that kind of expansion, we actually do a surgically assisted. So the surgeon will go in there and cut the buccal plate so that when we expand, the buccal plate goes with it instead of trying to slam it through that buccal plate. And then you could do a lot of expansion on the patient, and then when it all heals, it fills in. So you can do it on an adult, that more skeletal expansion, but it requires a surgical assist. The other thing too, though, is there's a misconception about the lower arch. You really can't expand the lower arch. Like our jaw is one solid piece of bone, and there is a dental alveolar process, and you can, to some degree, remodel the shape of that, but you can't take the mandible and make it wider. The maxilla has a suture down the middle of it, so you can actually, on young patients, you can actually open it and make the maxilla as 2 different bones, make it wider. And then that will fill in the middle, and it will actually be a wider maxilla than it was. Mandible doesn't have like a suture down the middle where you can split the 2 halves and make it bigger. So in the mandible, we actually don't, I mean, when we say expansion in the lower, we're only really just kind of taking lingually tipped teeth and kind of uprighting them, or maybe through the bicuspids and canines, maybe reshaping the cortical plate a little bit, but we're not actually like cranking out on a mandible. And sometimes you'll see a patient wearing like a removable retainer that's got a crank in it. It does not make the mandible wider. It just can't. All it can do is tip the teeth out. And so when I look around today, there's orthodontic practices that are like obsessed with not extracting any teeth, and they way overexpand people. And so when they overexpand to get all the teeth to fit in, the teeth literally look, when they smile, the teeth, you can tell that the teeth are all tipped out like this, all the way around. And what happens is the minute that patient doesn't wear their retainer, all the teeth just come slamming back in, because crowns do not want to be way out over the roots like this. They want to be over the roots. And so we see, especially here in California, you see a lot of overexpanded people walking around, and those kids have really bad relapse when they don't wear their retainers. And it's just not a stable position for them. So we don't generally just expand just to expand. Usually if we're gonna do that skeletal expansion, it's because the maxilla is deficient and we need it to be bigger. Then if it's not that problem, then we're just dealing with maybe a little bit of dental alveolar expansion that can be done with an aligner. But aligners are better at it than braces. Invisalign has come out with a thing right now that's like it's a really hard, almost like a splint that they've created the same way where it has stages and the patient wears it in the roof of the mouth and every 2 weeks or week they put in another one that's a little bit bigger. So they're trying to figure out a way to do this kind of skeletal expansion without having to put in a bonded RPE. But I'm sure it works. I've never used it, but they're not using their aligner for that. They're using like a really hard material to do that kind of expansion. So aligners and braces can only really do dental alveolar. They can move the teeth out and maybe remodel the alveolar process a little bit. But true bony expansion is done with these rapid palatal expanders on young people. Did that answer your question? Yeah. Okay. Did you have another question?
There was a follow-up of, you answered it.
While I was talking? Okay, good. Do you guys have any other questions? Yeah.
I have a question about perio or perio ties into these things. How do you gauge, like, I'll refer to the lateral ceph. Is there a point where you can tell that if you advance the incisors, you're going to create too much bone loss buccally or facially?
Yeah.
And do you use the lateral ceph to gauge that?
It's a combination of the lateral ceph and looking clinically at the tissue. So you can definitely see on a lateral ceph. So again, we talk about like that starting inclination. And I was just having you guys kind of visually look at it and go, does it look tipped back or does it look flared? But when we do our full ceph tracing, in fact, the iteration of the software that's going to come out in April is also going to have a new traffic light that will tell you whether your tooth was too proclined or not to start. If a tooth has an ideal inclination. If it's too proclined, it tends to get recession. And then if we try too hard to get the root underneath it, we can cause fenestrations and stuff like that. And it depends a lot because you can have a patient who's like a younger patient who has very good ability to heal, where they actually remodel that bone quite well. And then you can have somebody else where they don't do it well at all. And so older patients, like if somebody's in their 40s and 50s, there's just a lot of like, how far can you move that forward? It just has a lot to do with all of their things. Like, what does the tissue look like? Does it look like there's bone in front of that? And what does it look like on the ceph? Does it look like we have bone? What is the angulation of that tooth to start? Is it already proclined or is it kind of upright? Because all of these things together help us determine whether it's periodontally okay to move that forward. And there's probably a lot of people walking around who've had teeth by orthodontists and general dentists who've had teeth straightened, where if we were to pull the tissue off and look at the bone, where there was a little bit of recession on one, and where maybe a patient has gone and gotten a gingival graft done. But usually the benefits of the ortho even outweigh a little fenestration here or a little bit of recession there. Ortho doesn't just take those teeth and drop them on the floor. Nobody ever just gets their tooth pushed right out of their mouth. But so this one study that I read just the other day was like one where they went to ortho-treated cases and they did CT scans to actually look at whether there was bone loss or fenestration, stuff you'd have to actually pull the gums off to be able to see. And what they found was exactly what we were talking about here is if you tip a tooth too far forward, you're more likely to get recession. If you tip it too far back, like in a class 3 case where we're trying to tip them backwards, then they can get bone loss. Younger patients had less bone loss than older patients. Aligners cause less of that problem than braces because aligners actually, because of the torque problem, like they don't torque that well. It's really hard for them to take a root and push it too hard against the cortical plate to cause a fenestration, whereas a bracket could do that. If you have a bracket with a lot of severe torque, it actually could eat away at a cortical plate or cause root resorption. So aligners, just because they're weak a little bit, they can't cause as big of problems. But if you sit and just keep pushing those teeth out, eventually you're going to procline them to the point where it causes some problems. So the overall thing was basically like, don't tip them too far forward, don't tip them too far back. Younger patients have lower risk than older patients, and braces, if you're really pushing the envelope, can cause more problems than aligners. Was kind of the overall conclusion of that. Did that answer your question?
Yeah, and then one last question. For patients that have just gotten grafting, how long do you wait before treatment? And do you have to go a lot slower? Is there like a number that you...
There is a perio protocol for, so people who have periodontal disease, you never do ortho when they're active disease. They have to have their disease under control. But generally, if we're doing aligners, we move teeth slower if they have perio problems. So we want more aligners with smaller activations per stage. And then with braces, we'll avoid things like putting bands on teeth that could irritate and cause more recession or more bone loss. So there's a few protocols that we follow for people who just generally have had perio disease. As far as, there's a lot of conversation about whether it's better to do a gingival graft before the ortho or after the ortho. In my mind, you know how like if you're starting to get a recession, you want to get, the earlier you do the surgery, the better the outcome, because the bigger the defect, the less predictable the outcome will be. So for me, it's like if you fix it early, you're going to be more, like a lot of the periodontists will be like, well, just do your ortho and then we'll do the surgery. But I'm like, but if I make the defect get worse during ortho, then you have less chance of being successful afterwards than you do now. So I'd rather you do it now and be successful, and then we'll move the teeth and do it after. But there's different opinions out there. As far as when, like if they have a graft done, you just have to wait for the inflammation to go away. So when it's healed enough that there's no longer that red look to it, and it looks like it's healed, and that, because we don't want to move teeth where you have a bunch of inflammation. So whether it's a root canal that needs to be done, or whether it's a perio problem or a recent surgery or whatever. The only thing that I wouldn't, where that's not the case is when we're extracting teeth for ortho. If we extract teeth, we'll start moving teeth right away. But perio, I would wait until things look healed and the patient's comfortable and the inflammation's gone down. Yeah. What was your question, Jenny? Yeah, it's interesting. There's cases where you can take a tooth that actually like has a big recession on it, and they actually get the tooth back into the bone, and things actually do heal around it. So if you were to tip a tooth out way too far and get bone loss and then try to pull it back, I don't think the bone would grow back up that. So if you were like, and that's another one of those topics out there where like, it's called round tripping, where if we put braces on, you have a lot of crowding, everything just tips out until it gets straight. And then you do IPR, then pull it all back. You could potentially have some bone loss that you would never get back. And so sometimes people get really uptight about not doing any of that, where all IPR to make sure that teeth get straight without ever getting tipped out. And I'm just not a fan of that, because I'm like, really? Like you're gonna just sit and shave away all the tooth structure just to avoid tipping the teeth out a little bit? If they have healthy bone and healthy gum on their teeth, I would rather tip the teeth out than just sit and grind all the teeth away. But definitely there's a point to which if you tip them way out there, then bring them way back, you're going to definitely probably have some recession that's not recoverable, that's not reversible. Yeah.
Some of these cases that theoretically we were doing round tipping by putting brackets.
Anytime you put brackets and just, but you notice those cases, I'm always like, let's look at the gums, let's look at the bone, let's look at the starting position of the teeth. That, we're usually doing that on cases where the teeth were already kind of upright, and they can tolerate advancement because they weren't already advanced. If they were already out there, I wouldn't just tell you to keep going. Then we're gonna say, well, let's take teeth out. Or if we're gonna do IPR, like it's most productive in my practice to do all the IPR at one appointment. So I'd rather get all the teeth straight, have them come in when all the IPR can be done at one appointment. But if they have thin tissue and I'm worried about recession, then I'll do IPR staged all throughout the case, because like whatever contact is straight, maybe on day one, we have all these crowded teeth, but I have two contacts that are straight. So at day one, we'll go in and do IPR on those two straight contacts. And then maybe in a month, 2 months, there's a few other contacts that got straight. Then they get IPR. Then we keep going. So we're using the space that we made with the IPR to get the other teeth straight to limit how much we're taking them out like this. So when I'm worried about how thin the tissue looks or whether they have enough bone, I will take more time in the clinic to come in and do IPR all throughout their case to limit the round tripping. But if it's not going to be that much and they have really healthy looking gum and bone, I would rather just get all the teeth straight than let me come and do all the IPR at one time and then bring them back. It's more productive for me in my practice. Good questions. It's fun to learn ortho, isn't it? Did you guys enjoy learning some ortho today, thinking about this stuff? I hope you come back and keep taking these, because it's a whole nother language that we don't speak, you know, and things sometimes don't make sense. As you come back, you're like, oh, okay, that clicked now. And so we just keep, all the important stuff you'll keep hearing over and over and over and over. And, you know, different applications, different cases or whatever, but the stuff that really is important, we just keep talking about it, and other instructors will talk about it in a different way. And things that you're like, wow, if I went back and sat through that first day again, there was probably things that were said that I didn't get. And now that I've been in these courses, started to hear like, oh yeah, that makes sense what you said, but before I kind of was like, okay, I'm not sure what that means. But it's fun. If you guys enjoyed it and you're like, I really like this really is opening up my understanding of mouths and teeth and doing dentistry and this whole world, like just keep going. It's really fun. Yeah. No, we have a lot of just bracket cases. We have a lot of only aligner cases. And then because this idea of doing hybrid is new, I'm trying to put in as many of those as I can, because it's not, traditionally people have either treated with brackets or aligners. And it's only been in the last couple of years that we've really started to do, like, these hybrid cases are amazing. So we have cases and I'm trying to put them in. And so I think it's a pretty good mix of like all bracket, all aligner, and then some hybrid cases. But hybrid is pretty amazing. Like, if you would have asked me that 8 or 9 years ago, I would have said, if the patient lets me choose, I would say brackets, because I felt like I could do a better job with brackets. If you ask me that today, I would say hybrid, because they're just so effective at the beginning. And then it's just so nice to get them off for that patient and then to do all of your little planning that you need to do. Like, finishing cases is kind of hard in braces. You know, you get to the point where you're like, I'm 90% happy, but there's these little things. And so then you start doing these little bends in the wire to try to adjust these little things that need to be adjusted. And it's hard to do that with bending wire and repositioning brackets. But having a digital thing that just moves that tooth a little bit for you until it's perfect, that's really easy. In fact, I used to do it in my own practice where I'm like, you know what, this case is just not getting any better, but I'm not perfect down here on the bottom. Let's just take the braces off. I'll make your retainer. I would take an alginate impression, because I didn't have a scanner, send it to my ortho lab, and they would cut the teeth that weren't perfectly straight off of the model. Maybe it was an upper lateral or it was an upper central or whatever. They would cut it off the model, and then they would wax it back in perfectly straight, and then they would make me a retainer, which was basically an aligner, off of that, and then I would give the patient a new retainer to just tweak those final little things, because I just couldn't do it in the wire. Not skilled enough to be able to do it in the wire. And so for me today, I would say I would keep my patient in brackets as long as they were willing, but I always would finish in aligners because it's just so much easier to finish in aligners. And the patient's always happy to get their braces off and get the aligners in there. So that's why we're creating a system right now that's going to support that idea financially and make it the best option for you and your patient. But yeah, because you see these cases where people like, yeah, you can do it with an aligner, but it's going to be a long struggle. And why not just throw brackets on and knock that out and make it easy? So that's why I showed you today those 2 cases where one took 19 months with just the aligner and still didn't get straight, and the other one that did 15 months with brackets first and started out worse than the other one and was like, that's pretty awesome. So hybrid's great. Yeah. A lot of times, that's why I like the software. When I'm able to show them, like when they see, because they look in their mouth and all they see is the hole. And it's hard really to see what's going on in their mouth. But when they actually see a 3D model and they can see, once the teeth are straight, they can see how crooked theirs really are. And then you're like, what I'm wanting to do is before we put a permanent restoration in here, I really would like your teeth to look like this, functionally and aesthetically. And I mean, we don't have to, but I just want you to see the value in that. And once they can visualize that, now before I'd have to send that to an aligner company for them to even be able to see that. Now I can create it chairside in a couple minutes, and so that they can visualize it and go, oh, I wasn't really thinking about ortho, but now that you showed me that, I can really see why that would be better before I place my implant to do that. And they might not. They might still just place the implant in there. And I just go, well, just so that you know, like if later on you decide to get ortho, we're gonna be limited now because we didn't do it before this. And it's just it's a tool to help people. And you know, they do what they want. I'm not gonna force people and say like, you have to do ortho first. But if I can help them see what I see, which is look at how beneficial this will be if you do it first, and they can also visualize it, then you know, chances of you getting to do that is a lot higher. And every case I've ever restored where I did the ortho first, I've always just felt better about it. Like when I would have patients come back into my practice where I did upper crowns or veneers from bicuspid to bicuspid, but I didn't do anything on the lower, it would make me mad. You know, they'd walk in and I'm like, I hate seeing that because that's not how I fix people anymore. Like I've seen so much the benefit now of getting the lower arch and sometimes the upper too before the restorations, because sometimes I have to cut away too much tooth surface or the gingival height margins aren't right. And I just kind of hated seeing work I used to do before I was doing ortho, you know? And so seeing that stuff come into my practice made me go, sometimes I just have to give the patient a great deal and be like, look, I know you didn't want ortho, but I think the benefit to you is gonna be so great that like, and I'm gonna make plenty of money off of doing your restorations, like $1,500. 6 months, let me straighten your lower front teeth. And then we'll bleach them, we'll make them look all nice, and then we can do your upper restorations, then everything will look nice. And they're like, okay. And that kind of stuff, then when they walk back in and I'm like, that looks amazing. That's fun, that's cool stuff. And so it's partly convincing yourself, and then part of it is just once you're convinced, it's easy for the patients. I mean, really the patients trust you. And so when you're like, I know this is the best way to do this, I know this is the right way to do this, they'll usually find a way to make that work if that's what you feel is gonna be best for them. So it's learning how to see it, understand it, communicate to them, but then also confidently, you know, and once you've seen your own work and you're like, I hate that work that I used to do, and I love this stuff, and I talk to patients that way, they're like, yeah, you know, like, look, I can just do your upper front teeth. In fact, I've talked people out, you know, they come into my practice where they were diagnosed somewhere to have a whole bunch of veneers done, and I go, well, I'd make a lot more money if I cut all your teeth and put veneers on. But really, if we do the ortho first, I think you would look amazing with just 4 veneers on just your 4 front teeth, because those are the color and the shapes and whatever, those don't look good. But I don't think you need all these other veneers. So why don't we do the ortho? Let's whiten your teeth. And if we do all those veneers, it was gonna cost you, you know, $20,000. If we do the ortho and the 4 crowns, it's gonna cost you like $10,000, but your whole mouth got fixed, you know? And like, at the end of the day, I'm like, I literally made less money. I would have made more money to just prep everything and been faster, but I would have hated it because now I know the right thing to do was to do the ortho and prep fewer teeth. And it looks better at the end because they have more natural teeth. And then those 4 that I did blend right in because everything else is natural. And so you start doing that kind of stuff, and then that's when you get these referrals coming from specialists who are like, everything that comes out of that office looks great. You know, it just feels like the right way to do it. And that kind of stuff is so rewarding. More than just financially, like it just feels good to do things the way that you're like, that's the right way to do it. So. Well, thank you guys so much for coming. It was really nice to spend the day with you. I hope that you come back. Thanks.